Professor Waitt, pleasure to welcome you to Radboud UNC. You're the NIHR Professor of Clinical Pharmacology and Global Health in Kampala. I've always been fascinated about why people end up where they are. Interested to know for you how it was that you ended up where you were. Was it an event or a person in your life that inspired you, or did you kind of stumble into it?
So I think the interest in global health broadly, and I know that definition has many meanings to different people, but even before I went to medical school, I spent the summer between leaving school and going to university working in a mission hospital in central Thailand, and that totally changed my whole life in many, many ways. And it opened my eyes to some inequity and disparity, but it also opened my eyes to the fact that health is more than just the absence of a physical disease, but it's this complete state of physical, social, psychological and spiritual well-being, and that very wonderful things can be done with scarce resources. So I came back from Thailand, went into medical school, and then every time I had a chance to do a placement overseas, I would. So after I'd qualified, I ended up doing my PhD in Malawi on tuberculosis. And that again confirmed to me that I want to do something that I can see the impact to patients. And that was really how I got started in global health and why I've ended up in Africa for most of my adult life.
The Milk Project looks at drug transfer into breast milk. Can you tell me a bit more about that, how it came about and where you are at the moment in terms of the project and perhaps what lessons you've learned to date?
Yeah, so the Milk Project is, it's a very simple acronym. It's the Maternal and Infant Lactation Pharmacokinetics Programme. And for me, it all actually started both professionally and personally after I was breastfeeding my fourth child. And I had been really ill in that pregnancy and on multiple medication. And I was finding it very difficult to get information, but also very difficult to advocate for myself. And when I started to look at the literature, I realised it was because the evidence simply wasn't there. And doctors were tending to take a very cautious, just don't breastfeed if there's any doubt attitude. And that wasn't what I wanted to do. And I thought to myself, if I'm feeling disempowered as a clinical pharmacologist, how do most women feel? But not only that, I've actually got at my disposal the tools, the clinical trials tools, some of the pharmacokinetics. I had a BSc in pharmacology as well as a medical degree. So I kind of realised I can make a difference. And so there was a very, very clear turning point. I can almost pinpoint the day. And I wrote my first grant, which was an Academy of Medical Sciences starter grant, really to just start developing some of the methods and the feasibility and acceptability of the work. And that was, 13 years ago, so the rest has gone on from there.
You're a science communicator as well. How important is it to engage with the community and bring them along? And how do you do that in a rural African setting? Do women need to understand? And how do you test that understanding? How do you tackle the whole concept of informed consent when you're dealing with something as complex as PBPK modelling?
So in some respects, things are complex. But if you give any mother anywhere in the world, a pregnant or breastfeeding woman, you give her a medication, her first question will be, is this okay for my baby? And it almost doesn't matter what culture she's from, what level of education she has. There's some question that reflects that kind of, is this safe? And how can I trust you? And so I think sometimes we can make things a bit too complicated. But we also have to be really careful not to assume. So how do you communicate scientific concepts like perhaps genetics and genetic variability to somebody whose language doesn't even have a word for a cell and they've not had even a primary school education? How do we explain that? And there are ways of doing it, but you need to actually engage communities and ask them. So for us, one of the key things was having a community advisory board, which consists of different community leaders, cultural and religious leaders, young women with lived experience of conditions, some of the male partners, and we bring them all together and we discuss ideas. And that's led to many studies that, as a scientist and PBPK modelling team, we have also done some studies that are basically linguistic anthropology as well. Like, how do we translate these terms into a language in a way that is clear, acceptable, but also respectful? And we've published a couple of papers on that. So I feel like having the community involved at every single stage is absolutely key. So on my core team, I have a public engagement officer, a full-time role, and I also have a full-time peer mother who serves very much as a kind of a conduit between the research team and the communities, and she'll give us really honest feedback if we are not getting things right.
Much of your work takes place in an African setting with very different kind of healthcare infrastructure to what we have in Northern Europe. What can high-income countries like the Netherlands, for example, learn from your work, especially around things like inclusivity in research?
So I think there's definitely a huge amount that can be learned, and I think all partnerships should be multi-directional. I sometimes hear people talking about North-South partnership, and I find that term slightly problematic because it almost implies that some people have more knowledge and that the knowledge moves in one direction. And I think lactation pharmacology is a classic example. So for example, I often read papers or protocols that talk about ethical and logistical constraints in recruiting mother-infant pairs, particularly in doing the full day of sampling or sampling from the infant. And I always respond by asking, what are you talking about? Because over the last decade, we've recruited about 400 mother-infant pairs. We've had full recruitment. For the PK parts of the studies, we've had almost no loss to follow-up. It could even be zero, but I'm scared to actually say that in case there's been one or two. But we haven't had any of those challenges that other investigators report. And I think one of the key things is that community engagement and involvement. I think it's the credibility and the trust. I think it's the fact that the communities see the need, and the women, I mean, when we started working with HIV, all of the women, you know, it was affecting them directly. They were frightened about mother-to-child transfer of virus. They didn't want any harm from the drugs. But in our setting, the only really acceptable, affordable, feasible, sustainable or safe infant feeding option is breastfeeding. So they were very stuck. So a lot of women wanted to be part of the solution. And so we haven't seen those challenges. So I think clinically, if you want to learn how to do that, come and speak to my team in Uganda, and maybe even send somebody down and you can visit the site or invite one of our team to your site. So I think there's a lot of very hands-on clinical learning. But conversely, we can learn a lot from the higher income countries in terms of the bioanalysis, some of the PBPK techniques. We're only just getting started. So that's where I see the partnership as being very beautiful.
Yeah, and that's interesting. You should talk about North-South collaboration or South-North collaboration. But where do you see this going in the future, the global collaboration in your field?
So I think there are many principles in how we do these studies, in terms of like best practice for study design. And we could talk about, for example, how do you do a sample size calculation when there's no prior data? What assumptions can we make? What about milk composition and volume? How do we measure those things? There are some very general principles. And the World Health Organization is developing various toolkits. So for example, there's already the antiretrovirals in pregnancy toolkit that's online. And when you look at that, you can see that many of the principles could apply not just to HIV, but across all diseases. And I think when you think of the fact that worldwide, more than half of all mothers require some kind of medication in pregnancy or breastfeeding, there is a huge amount we can do, because this is a truly global problem. Like breastfeeding, pregnant and breastfeeding women are a key part of every adult society in the world. So it's not just a low income, you know, low resource setting, neglected tropical disease kind of situation, but neither is it a high income problem. It's a global problem. And with epidemiological shift, high income countries are getting more outbreaks. They can learn from us. We're getting more obesity and non-communicable diseases. We can learn from you. So it's trying to find the platforms with which we communicate. Online resources, for example, perhaps websites. I mean, again, I'm sure you have some examples of websites where some of these resources could be hosted.
Professor Waitt, thank you very much.